So first question, this is what you have. Clinical finding, right? 32-year-old G1P0 with intrauterine demise at 30 weeks and bleeding from all IV sites. This is I don't want to give you a bunch of case to read. I just give you buzzwords, showing you that when you're reading a case study, you should be looking for these buzzwords and circle them and then put them together, connect the dots, right? I give you a physical exam, petechia, right? There's a nosebleed. This is the vitals of the patient, tachycardia, temperature 100, blood pressure 100/70, and respiratory rate and saturation. Think about it. All you need to do is to figure out what you need to do when somebody have intrauterine and demise, right? She's 32-year-old. A baby is 30 weeks old. And then the baby is dead inside the uterus. What is the complication? What is the priority function for you? Bleeding from all IV sites. That is a buzzword. Petechia. That is also a buzzword. Tachycardia, heart rate of this and that. What do you think is going on, and what do you need to do for this patient? So this is what the question is: which laboratory data the nurse should expect? Select or apply. The content here is you have a female 32 G1P0 who had a baby, and the baby is dead inside the womb. What it should be your concern? This is a classic NCLEX question. It's a test taking strategy and content, full of content. What do you think you should worry about when you see this intrauterine demise for a patient who is 32-year-old and has a baby that is 30 weeks old? What should you worry about? I don't want you to give you a long case, but I think the priority information asks you what lab work do you expect? Do you expect a low platelet, low hemoglobin, low INR, low PTT, low PT, high fibrinogen, and high D-dimer? What is an expected finding for these conditions? You have to make a diagnosis. That's the test taking strategy. A patient who had intrauterine demise, you have to make the diagnosis. After you make a diagnosis, then you manage the patient. What will happen to this patient? And the content is all over. If you need one and you're hearing my voice for the first time, ADAPT NCLEX review, easy access on YouTube, the best you can get for you, easy way, and you can try to read something about it. So check it out. You will love it. Anyway, what do you think the patient should show? What kind of signs and symptoms? The content here is intrauterine demise is a DIC, disseminated intravascular coagulation. Based on that, intravascular coagulopathy, basically, there is a coagulopathy associated with that, right? And it's disseminated, it's spread all over, and there is a consumption. This is a consumptive problem. I'm consuming everything that make you clot, everything that will cause you bleeding, stop bleeding. I'm consuming all of it. So that is the key. Therefore, in this patient, I give you a clue. I give you a clue, right? I told you she's having petechia and nosebleed. Tell you platelets should be low. If you're bleeding, your hemoglobin should go down. If you're bleeding, then your INR should be very high. If I'm consuming all your coagulopathy, right? It's not going to be low, right? If you're bleeding, your PTT and the PT, all of them should go high. That is the condition that causes you to bleed. And your fibrinogen should what? Should not be high because that's what help you to improve your clotting factors and other functions. So high fibrinogen is inconsistent with DIC. It's supposed to go down. But when you have clots, a bunch of clots will release D-dimers. So that will show this. So this is what you're supposed to see. This is a classic DIC. If you've never seen it before, I've given you the content right here. DIC, laboratory work. This is what you expect. ABG is your right answer. Okay. Next question. A nurse is aware of 3 clients in emergency room. So there's 3 people, right? Who are those? This is what they are. 65 years old. How do you read case study? Go for the buzzword. As you read the first two lines, you should figure out what is going on with this patient. 65-year-old, left lower quadrant pain, nausea, non-bilious emesis. Like I said, I'm putting the buzzwords together, making the case short and simplify it. When you're reading it too, you should be doing the same thing, right? No hematochezia, no bleeding, right? Report anorexia, does not want to eat. No past medical history, no surgical history, no allergy. Vitals, febrile, tachycardic, blood pressure, and respiratory and saturation. That S1 and S2 is normal, lung is clear, abdomen is soft, but yes, left lower quadrant tenderness to palpation, and pulses is fine. Did you figure out what this patient is suffering from? You should be able to make a diagnosis. Number B, 45-year-old, history of cirrhosis of the liver with increasing dyspnea, abdominal distension, vitals, 100.5, tachycardic, blood pressure is down, and respiratory rupture. The patient has chloric ectorate, right? Respiratory labor, tachypnea, and a clear breath sound. And then the abdomen is distended, right? Plus two pulses bilaterally. Next one, 29-year-old college student with sore throat, fatigue, arthralgia, chills for 2 days after a night out. Report left upper quadrant pain this morning. Tachy, temperature 100, heart rate of 99, blood pressure of that and that. What do you want to see? Who do you think is a problem? Who should you see first? So this is the patient you have. Which client you think the nurse should see, A, B, or C? Which client should be seen first? This is what you have. Who are you going to see first? This is the patient. Who are you going to see? 29-year-old, a college student, complain of sore throat, arthralgia, chills, left upper quadrant pain now, heart rate of 105, temperature, that blood pressure is this, right? B is a 45-year-old, cirrhosis of the liver, increased dyspnea, abdominal distension, and all these signs with the respiratory shallow, breath sound, and abdomen distended, right? Then we have 65-year-old with left lower quadrant pain, abdominal, there's no hematochezia. You have temperature 100.5, 101.5, left lower quadrant tenderness. Which of these patients you should worry about? Make a diagnosis and see whose problem is the most important. This is all content. I mean, I can't stress this enough. You can go anywhere to get your content, but make sure you paying attention to details like little thing. There's no formula to the NCLEX. There's no formula. I said, hey, prioritization. I have to do this. You got to do ABC. You got to read it from below. You got to do this and that. No, look at the situation. If it works for you, fine. But there's some questions that you can see. What is going on with each patient? And who do you think you should give a second to? You got to make a diagnosis. If you do that, the case studies are easy. What is wrong with this patient? What is wrong with this patient? And what is wrong with this patient? Just tell me what is wrong with this patient and just go and follow one word in the case. No. What is wrong with this patient? Number one, has left lower quadrant. I will underline the buzzword 65. I have left lower quadrant pain, some nausea. Then I have fever, right? I have left lower tenderness, right? Left lower quadrant tenderness. I've not given you lab work, but this patient is a classic presentation. The age, the complaint is consistent with diverticulitis. I'm not going to tell you what all the other ones is. I'm not going to tell you. It's your job to figure it out, right? It's your job to figure it out. But NCLEX will start doing this to you, which they do. They are not going to give you diagnosis, and you have to figure out what do you think this patient is suffering from. I'm giving you a clue. It's 45, he has liver cirrhosis, and he having dyspnea. His abdomen is getting distended. But look, he has some fever. Distension alone is not enough. He has some fever now, and he's tacky, right? Abdomen is distended. He has shallow breath and breath sound, but his breath sounds are clear, right? What do you think he's suffering from? Then you have a college student who went out enjoying himself. Now he has a sore throat, arthralgia, like a flu-like symptoms, and they have left upper quadrant pain. What is your buzz rate? It's tacky and that. So as you figure out what is wrong with these patients, then you will know that the person is supposed to see. Who are you going to see? We should see number C. We should not see B or A. They all have a problem, but C is more dangerous. Why would you see C? Because if you make a diagnosis, if you figure out what is wrong with C, you will know why we have to see C. And you will figure it out. Therefore, select three findings. The next is select three findings that is concerning for client B. What is concerning for client B? Client B is 45-year-old. He has cirrhosis, increasing dyspnea, abdominal distension. He has fever, tachycardia. The blood pressure is there. He has scleral ectorate, respiratory is shallow, clear breath sound, and abdominal distension. So, which one is concerning? Is his temperature? Is his shallow breath? Is his clear breath sound? His heart rate of 104? His history of cirrhosis or jaundice? What do you think is the most important thing you should worry? I can tell you, jaundice, you're not going to fix the jaundice right now. So jaundice should not be your priority. Cirrhosis of the liver, you're not going to fix it right now. That's not why it came in. It's consistent with having cirrhosis of the liver. His breath sound is clear, so why would you have to pick it as a priority? So his temperature, he has shallow breath, and a heart rate of 104, his tachycardia. Those are the priority function that you should worry about. Now, I said, which intervention the nurse should expect in the plan of care for C? So this is C. Look at it carefully. I pick it as a priority. So look at it as I pick it as a priority. If you don't be able to figure out what is a priority, at the end, I will tell you what this patient has. 29-year-old college student, sore throat, fatigue, arthralgia, chills for 2 days after a night out. Report left upper quadrant pain this morning. His temperature is 100, is slightly tacky, blood pressure 100/70. What do you think is this patient have? And before you can figure out what you need to do for them, you have to make a diagnosis. This is what I keep on telling you guys. But my hands are tied. I got to tell you why this is dangerous. The keyword is a college student. Keyword, he went out. That's the buzzword. And now he has what? Flu-like symptoms. He has flu-like symptoms, and all of a sudden, he has left upper quadrant pain. This patient has mononucleosis. We call it the kissing disease. He went out and enjoyed himself, and now he has mononucleosis caused by Epstein-Barr virus. That's why he's slightly tacky. The blood pressure is in the low side. And then you got to figure out what is going on. Why does he have left upper quadrant? That's your job to figure out now. Therefore, what does he need? He needs CT scan to figure out if he has bad problem associated with this issue. You will need complete blood count to check if he's bleeding. That's the bad problem. He may have a splenic rupture or liver rupture. Those are the key aspects. So you see how simple the case is, but if you just follow ABC, you can figure it out. You just have to make the diagnosis. You see, oh, this guy has mononucleosis. The problem with mononucleosis is a rupture of your spleen on your liver. We don't need paracentesis, right? We need 218-gauge IV because we got to resuscitate you. We don't need to beta block him. He's getting what tachycardic because he's bleeding. So there's no need to beta block him. You maxing the effect of the hypertension. At the same time, you drop your blood pressure. And we should prepare for surgery. So those are the signs and things you should do for this patient. Now, the next should anticipate which of the following intervention for client A. The client A, I told you, 85, left lower quadrant, pain, fever, is what? Diverticulitis. What are the management you expect? It's a GI problem. Most GI problem, they're going to be NPO, right? They may need IV fluid, antibiotic, right? They don't need engine tube until you're vomiting. This patient, we don't have a CT scan. So what do you think is the plan of care you should include on the patient that you suspect? You suspect number one, A, as diverticulitis. What do you want to do? Acute diverticulitis. What is the management of that patient? What is included in that? So what do you want to do? Tell me, what do you want to do with this patient? What do you want to do? Of course, I told you we got to make this patient NPO. What else are you going to do? What is your plan? What is your plan? What were you going to include in your plan? He's going to get a CT scan to figure out what is going on inside him. So that's another plan of care that you got to include. We don't need to type and cross. We're not going to transfuse it. The patient is not bleeding. And you should avoid anything going into the rectum. When you have diverticulitis, there's going to be perforation. So there's no colonoscopy. If there's no colonoscopy, there's not going to be enema. What do you guys think about number F, intravenous anti-infective? What do you think about it? What is intravenous anti-infective? What is that? Sometimes your board will use this word. What am I trying to say? What is this? Think about it. Is it diverticulitis? Why would I put this there? What is an intravenous anti-infective? What word is that? What does it represent? Can you figure it out? What do you think? It's an antibiotic. This is expected, right? If you have diverticulitis, you get antibiotics. So this patient, you get this in addition. So watch for these words as they put it to trap you. So this patient will get antibiotic. Which of the following orders the nurse should prioritize for client B? So who is client B? Look at it. It's a 45-year-old cirrhosis of the liver with increasing dyspnea, abdominal distension. It's febrile, it's tachycardic, blood pressure is that. He has scleroticate, and abdomen is distended. What do you think is wrong with this patient? What is wrong with this patient? The clue is liver cirrhosis. So what is wrong with that patient that is looking like that? Who can make a diagnosis for that? If you can make a diagnosis, that is great. That is wonderful. That means you know the content about liver cirrhosis. What do you think is wrong with this patient? This is why you got to put the words together. His belly is distended. He has cirrhosis. Probably he has ascites. But then he has fever. When you have ascites and then you have fever, what do we call it? Ascites plus fever. His labored breathing is due to the distension. It's all due to ascites, right? So that's why it's pushing on the diaphragm and the individual having respiratory issue. But he has ascites and then he has fever. So what do you call that condition? A liver cirrhosis patient, ascites, and a fever. This is what we call spontaneous bacterial peritonitis. That is SBP. The ascites is now infected. That is the key. So he has SBP, spontaneous bacterial peritonitis. Based on that clue I've given you, which of these are you going to prioritize? 25% albumin infusion, anti-infective, paracentesis, sequential compression device, and sips of clear. You got to choose one. Which of this will you prioritize? Spontaneous bacterial peritonitis. This is a concept, right? You know the diagnosis, prioritize one one that plan that you use, right? I want you to prioritize. Which of these will you give to the patient? You receive these orders. Which one will you prioritize? That's all. Straightforward. Which one will you prioritize? Will you give them 25% albumin infusion? Will you give them anti-infective? Will you perform paracentesis? Will you get a sequential compression device or sips of clear? Look at the diagnosis, and then based on the diagnosis, what do you think the patient needs? I can tell you that sips of clear is not, you cannot prioritize sips of clear regarding it. The guy is having issues. His belly is distended. He's having respiratory issues. He's feel really tired. What do you think? And it's febrile. What will be your diagnosis? Think about the situation, right? What are you going to give this patient first? What are you going to give? This patient require antibiotic first before we can think about paracentesis. There is no indication that is fluid overloaded. When you give them 25% albumin, it's after you've removed the paracentesis before you can do that. But antibiotic is much better. Albumin is given after paracentesis. So you get antibiotic, you get paracentesis, and then we give them infusion of albumin. Okay, so that's some of the things you should be worried about. Client A is ready for discharge. Which stitching is appropriate, right? What is client A? I told you he has diverticulitis. 65-year-old, female, left lower quadrant, nausea, non-bilious emesis, no hematochezia, no past medical history, febrile, tachycardic with the left lower quadrant tenderness. You know he has what? Diverticulitis. What teaching do you tell them? 2 to 3 liters of water a day, moderate exercise 3 times a week, daily Miralax, prescription for psyllium, and an adalimumab. Give me your answers. What do you think you should do for this patient? He has diverticulitis. He's going home. He has done well, ready to go home. What are you going to give him? What are you going to give this patient to go home? In terms of teaching, teaching is based on content. When they say teach the patient, you don't have to think far away. Don't think far away. Just think what you know. If you know it's appendicitis, teach them related to appendicitis. Don't bring anything in. If this is diverticulitis, think about the underlying problem. The underlying problem is due to like lack of fiber. So psyllium is fiber, if you don't know it. So psyllium is fiber, right? And do not over-select. It's a select or apply. If you know only two answers, pick them and leave them alone. After you have fiber, you should drink a lot of water to make your stool bulkier, right? Then you should exercise. You should not take laxative. It's a trap. People get trapped with that all the time. And why would you have to pick adalimumab? If you pick adalimumab, then you don't know the medication because it's not used for diverticulitis. This is an immunomodulator, right? And this is used for ulcerative colitis. It suppresses your immune system. Diverticulitis has nothing to do with this. There's no need to pick adalimumab, because I just put it there. It is a medication for Crohn's disease, ulcerative colitis. Expect your body to do the same thing to you. You don't need that. So this is wrong. These are the medication you give them. And that's the case. That's the case for you. Short case, but it's just prioritization, another way of thinking about prioritization, right? So I give you all the answers already. Any question? If you have a question, you can type it. I will fix it for you. Next question. This is your patient. The client arrived to the emergency room via emergency medicine service. Client report of what? Severe headache behind what? The right eye, right? The severe headache behind the right side. The pain is what? 9 out of 10 excruciating and worse with laying down and then to the right and to light and nose. He said, I usually get this headache sometime every 2 days at the same time of the same side of the head. Okay. It lasts for what? 30 minutes to 3 hours. No horror, cannot identify triggers. It's alert oriented. There's nasal discharge. There's meiosis, ptosis, and tearing of the right eye, right? The face is midline. GCS of 15. No drilling, no motor deficit. S1, S2 present. Lung cleared bilaterally. Abdomen is fine pulses. I intentionally give you a bunch of stuff, but you have to take your time and then try to fish out the buzzword, I call them. And the buzzword, look at the first two sentences and see if you see something. He arrived here at the emergency room. The client reports severe headache behind the right eye. Actually, I left the right eye. Right eye here. And it's usually 9 out of 10. It's excruciating, right? And it's worse when laying down to light and noise. I usually, keyword, get this headache same time every 2 days at the same side of the head. That is key. It's the same side every day, every other day, and it's behind my right eye. It can last for 30 minutes to 3 hours. I cannot identify a trigger. What is your physical exam shows? He has meiosis, he has ptosis, and he's tearing on the right eye. His face is midline. There's no drilling. Can you figure out, based on what I've told you, his headache, what is wrong with this patient? This is your option. Trigeminal neuralgia, there's subarachnoid hemorrhage, there's cluster headache, there's migraine headache, and there's tension headache. What do you think is wrong with the patient? The best way is to look at each diagnosis and see if there's any clue that I give you in this question that you can think, is this trigeminal neuralgia? Is this subarachnoid hemorrhage? Look at it, anything in it. Don't just jump the gun. Is this cluster headache? What tell me this is cluster headache? The buzzword. Is this tension headache? And is this migraine headache? So ask yourself. So you have 5 options. Which of this is classic to you? Which one do you think is the right answer? If you say it's a migraine headache, what do you see there? That tells you this is a migraine headache. If you say this is a cluster headache, what do you see? That tells you this is a cluster headache. If you think this is a subarachnoid hemorrhage, what do you see? That tells you this is subarachnoid. So you're supposed to choose one. It cannot be multiple answers. It can't be you can't have multiple headaches. There's only going to be one headache. There's only going to be. So it's one answer. You can choose a lot of answers. So one answer, what is trigeminal? And this is what I call buzzword. And then you go back to your content. In trigeminal neuralgia, when you're going to have headache, there should be something. I'll be telling you that, oh, it's usually unilateral, yes, but the face, I have to tell you something about the face, that when you touch the individual face, it's going to be like electric shock-like symptoms. I never told you anything like that. I never told you anything like that. Therefore, it can't be that. Subarachnoid hemorrhage, the individual will be saying, worst headache of my life. There's nothing like that, right? Cluster headache, it happened the same time, the same day, every other day. That's the clue. And it's unilateral, it's one side. Involve your eyes. And then you have tearing. You'll be tearing, okay? You tearing. There is tearing and runny nose. That is that. If it's migraine, what is the problem? There's no nausea in this patient. And there's no horror. There's no nothing trigger it. So this cannot be migraine. And migraine does not happen the same time, the same day of everything. And tension headache, you should be looking for a band-like symptoms. There's no band in the face. It will tell you this is the headache crossed my head like a band. There's nothing. Therefore, the right answer is cluster headache. This patient is suffering from cluster headache. Which additional finding the nurse should expect? If you think this is a cluster headache, what should the nurse expect? Client pacing in the room. Tight band-like pain. I've given you the answers, and you can figure out that, oh yeah, this is the clue. Pain behind the left eye. Nausea, electric and shock-like pain when touching the face. I've already said this. I've given you the clue already. Electric and shock-like pain when touching the face is trigeminal, so it can be that. Nausea, the guy never, if it's migraine, right? What do you think? If you think about it, if it's migraine, you get nausea. This patient is not that. There's pain behind the left eye. You cannot have pain behind the left eye because the guy, this is attention to detail. I intentionally said this to trap a lot of people. The guy has right eye pain. If he has pain behind the left eye, that means both. This become bilateral. Content. Cluster headache is only one eye. It's not both eyes. Therefore, it cannot be seen. There's tight band like pain is tension headache. So it's wrong. Therefore, it has to be this. Why? Cluster headache. If you stay still, it get worse. So you got to keep on moving. This is ADAPT NCLEX way of trying to trap you, use content to deceive you. I said questions, it look like the NCLEX because I know how they think. So this patient, client will be pacing in the room because if he stays still, he's going to have pain. So you got to keep on moving. All these things is not related to that. And next, receive the following orders: non-rebreather oxygen, sumatriptan, calcium channel blocker, and NSAID. Which order the nurse should prioritize? You know, it's a cluster headache. Therefore, what will you give to the patient first? What do you want to give it to them? What medication will you give it to them? Which medication do you give it to them first? That's the key, right? What do you give it to them first? Non-rebreather oxygen, sumatriptan, calcium channel blocker, and NSAID. If you know that is a cluster headache, go down to the pathophysiology. Go down to the pathophysiology and think about what is causing the problem. Don't just answer the question. I really want you to think. It's a cluster headache. What is the pathophysiology of cluster headache? It's due to vasospasm. It's vasospasm. A true medication for this condition is oxygen. You just give them oxygen and they may get blood flow, and oxygen will help prevent the vasospasm. All these medications are used for treatment. Sumatriptan, calcium channel blocker, NSAIDs, they are all used for it. But number one treatment for cluster headache is just give them oxygen, non-rebreather oxygen, and that is the key. Okay. What is the next first action? Okay. What is the next first action? So click on it. At 12 o'clock, this is what happened. The client became confused. GCS is 13. Client said, "This is the worst headache of my life. He's drooling and he has left leg weakness." So now this is the problem. Scenario has changed. He's not confused. GCS of 13. He said, "This is the worst headache of my life. Drooling and the left weakness." I'm trying to walk you through NCLEX way of thinking. Now, 12 o'clock, things has changed. What do you think is wrong with the patient? What would you do? What is the next first action? If that's the problem, what would you do? Get a CT scan of the head, assess client airway, perform complete neurological assessment, check blood glucose or MRI of the head. Go back to prioritization. Be sharp, adapt NCLEX way. And if you have to do one thing, which of this will you do for the patient? His condition has changed. He's confused. His GCS is 13. And he said, "This is the worst headache of my life." Therefore, if the worst headache of my life and he's drooling and he has left leg weakness, what do you think we should do? Tell me. You are the boss now. Give it to me. What should you do? Perform complete neurological exams, check their blood glucose, do MRI of the head, assess client airway, and then CT scan of the head. What would you do? If you are the one taking care of this patient, what are you going to do? Will you get a CT of the head? Will you assess the patient airway and perform complete neurological exams? Do you check the blood glucose? Do you like get an MRI of the head? Don't be trapped. Prioritization is content in disguise. Whenever, and I see that people like it's all over. It's because, I mean, if you just follow the fact that you just have to select something that is more dangerous, then you get it wrong. When you have heart attack, when you have stroke, which is this patient is having, any emergency, we always want to make sure we're protecting your airway. So airway is always important. Whether you have heart, when you come in with a heart attack, I don't care about Mona. I care about your airway. If because I can give you Mona all I want, and if you're dead, I can't do anything. Same thing. If this patient is dead because his airway is compromised, I won't be able to check their blood glucose. I won't be able to get an MRI of the head. I won't be able to do complete neurological exams. I won't be able to get a CT of the head. I got to make sure airway is intact and protect the airway. So if you choose C, we're wasting time. We can't do complete neurological exam. I know I need to get a CT of the head, but I got to make sure you breathe in for the CT of the head to happen. I know I need to perform neurological exams, but you got to be breathing before I can do that. I need to check your blood glucose. If you're not breathing, blood glucose is negative. I need to get an MRI. If you're not breathing, we have a problem. So let's assess the client airway. CT scan was obtained for the client after airway secured. Airway secured. What finding the next you expect on the CT? Epidural hematoma, subdural hematoma, subarachnoid, intraparenchymal hemorrhage. The key word is here. Where's headache of my life? What is where's headache of my life? That's all. You take the keyword. So which one the patient will say, where's headache of my life? Which one the patient will say, where's headache of my life? He's not going to say that for epidural hematoma. Epidural hematoma, you have lucid interval. You get banging your head, you fall down, you wake up, you say, oh, what happened? Then 30 minutes later, you cramp, you dead. Subdural hematoma, usually it's chronic, it's long standing, you have dementia, right? Subarachnoid hemorrhage is the one they will say, the worst headache of my life. The head is on fire. And intraparenchymal, usually you can't even say anything. So this one get a subarachnoid hemorrhage. Okay. And next, let's review the clinical data. Which of the following the next you expect in the plan of care? So this patient has subarachnoid hemorrhage. It doesn't matter. Think about it. It just had head injury with some blood in it. Which of those do you expect when you're taking care of a patient who has headache and now has subarachnoid hemorrhage? What do? Levetiracetam. Levetiracetam. This is Keppra, 50 milligram IV Q12. Neurological check every 4 hours. Enoxaparin, 40 milligram sub-Q. Sequential compression device. Antiemetic. Head of the bed, 30 degrees, and suction the client every hour. Tell me, which of those should you include in the plan of care? Which one? I can tell you they will need Keppra because to prevent seizure prophylaxis, it's for seizure prophylaxis. The blood can create seizures. So that's why head injury, usually you prophylax them with seizures. You should not be checking somebody with the head injury every 4 hours. No way. You should do it every hour. So you have blood in their head. They should not be getting enoxaparin. It's not good, right? Sequential compression device. Yeah, there's nothing wrong with it, right? Antiemetic so that they should not be coughing, right? It's good. And the head of the bed is 30 degrees. The head of the bed is 30 degrees. Is good, right? And suction every hour is not good. You shouldn't be suctioning the patient every hour. It's inappropriate. So the answers are A, B, E, and F. Okay. So this is a patient. Client arrived with friends after all-night party event. Client was observed snoozing and injecting a white powder. After the party, client became erratic and violent. Client is agitated, hyperarousal, and oriented to only self. The client pushed and spat on the nurse's face. Security was immediately notified. Vitals 100, heart rate was 115, blood pressure 160/80, respiratory of 18, SAT 98%, 95% in room air. Can you figure out what is wrong with this patient? Arrived with a friend after all-night party event. Client was observed what? Snoozing and injecting a white powder. After the party, he became erratic and violent, agitated, hyperarousal, oriented to only self. All these things should be telling you something. He pushed the patient, the nurse, spit in the face, and security was called. This is the virus. What do you think is wrong with the patient? What condition the client is experiencing? What action you want to take? And what parameters you should monitor? What parameters? Is this alcohol intoxication? Is it opiate? Is it cocaine? Is it diazepam intoxication? Based on what you pick, what is the action you need to take? For Bowtie, never look at the action, never look at the parameter, stick with the condition, make the appropriate condition. When you make the diagnosis, stick with it and say, I have alcohol intoxication. I'm only going to pick an answer choice that is going to answer alcohol. And if I pick an answer choice answering alcohol, I may pick an answer to do what? Monitor the patient. Don't flip back and forth. You have alcohol, opiate, cocaine, and diazepam. Then what do you want to do? So, key fact. Which one is this? Concept, concept, concept. Look at it. Powder injection is not irrelevant, is irrelevant. But the clue is what? Erratic, upper symptoms, violent, upper symptoms, agitated, upper symptoms, hyperarousal, upper symptoms. Then what? Pushes the nurse, violent, upper symptoms, tachycardia, upper symptoms, blood pressure is high, upper symptoms. Those are all upper symptoms. The patient is showing signs of upper central nervous system stimulation. Alcohol causes central nervous system depression. It cannot be that. Opiate, central nervous system depression. Cocaine, central nervous system stimulation. Diazepam, central nervous system depression. Therefore, cocaine. What action would you take? The guy is like spitting in the front of the nurse. You get restrained, whether you like it or not. You cannot put this patient in seclusion. That's not allowed. You can restrain them and then get order from the nurse doctor right away. But you cannot put them in seclusion. Then you check drug screen. So restrain and drug screen are your right two answers. Then what do you want to do? Which parameters do you guys want to monitor? Agitation, respiratory rate, drowsiness, and diarrhea. What do you think? What do you think? Which of those are you going to monitor? It's test taking strategy, right? Test taking strategy. The key word is when they give you questions like that, somebody taking cocaine, when they come in, they will be what? Intoxicated. After they come in, you should worry about withdrawal. This is test taking strategy that I want you to be. You should not be worried about intoxication the rest of it. The withdrawal can kill them. When they go into withdrawal, that's what they want to kill themselves. They want to go so happy that they cannot do that. So you come in with cocaine, I need to watch you for what? When you come in, intoxication. But then I should be worrying about you being withdrawal because the withdrawal symptoms is what is going to bother you most as you calm down. So we should not worry about agitation, is upper symptoms. I should be worrying about respiratory rate and drowsiness. Diarrhea is intoxication. Therefore, that one are your answer. This is ADAPT NCLEX. Thank you for joining us. As I can see, only like 11 people like this video, which is okay. You guys have a good day. Take care of yourself. Good luck. If this is new hearing my voice, you can subscribe to our channel or join our on-demand or the crash course. One will be coming up in the third week of July. You can email adapt me at www at no adaptnclass at gmail.com. And then if you need anything, just let me know. But take care of yourself and good luck. Thank you for patronizing. Best of luck in your exams. Bye.